The innate system acts as first responders, which consist of NK cells, macrophages, and DC. The loss of MHC1 expression in cancer cells, the upregulation of cancer ligands and antigens, and tissue damage signals secreted by neighboring cells all initiate the innate immune response. Typically, the first immune cell responders are natural killers in macrophages 1. NK cells kill cancer cells by releasing the Leydig granules, perforin and granzyme, and recruit other tumor-infiltrating lymphocytes, such as dendritic cells, macrophages, and CD8 plus cytotoxic T cells. Macrophages 1 can kill cancer cells with phagocytosis and also recruit T cells. Dendritic cells present antigens to T cells to help initiate the adaptive immune response. They also secrete IL-12 effector cytokine that promote Th1 and natural killer cell responses. Other tumor-infiltrating lymphocytes. The tumor-infiltrating lymphocytes found in breast cancer are predominantly T lymphocytes, specifically CD8 plus cytotoxic T lymphocytes. Like NK cells, CTLs can secrete perforin and granzyme granules that lyse cancer cells. CDLs can also differentiate into tissue-resident memory T cells that exist within the breast tissue. Tissue-resident memory T cells express high levels of immune checkpoint molecules that help eliminate cancer cells and have been found to increase breast cancer patient survival rates. CD4 plus T helper cells are also present, mainly Th1. Th1 cells polarize and secrete cytokines such as IFN gamma and TNF alpha and IL-2, which can limit cancer growth, interaction with APC cells, and activate macrophages. B cells produce the antigen IgG, which inhibit cancer cells' growth, and other specific tumor antibodies. The 3 E's of breast cancer. The 3 E's of breast cancer immunoediting hypothesis proposes that the immune system can both protect the host and produce tumor-stimulating immune cells. Cancer immune editing has 3 phases known as the 3 E's. The first phase is the elimination phase. When normal cells turn cancerous, they begin expressing tumor antigens, calreticulum, and produce NKG2D ligands. These mechanisms attract tumor-infiltrating lymphocytes. In the second stage, which is known as the equilibrium phase, the immune system prevents cancer cells' growth but can't eradicate the remaining cancer cells. Some of the cancer cells are then induced to create genetic modifications due to the selective pressures of the immune system attacks. These modified cells are then able to evade the immune response. During the final phase, the escape phase, cancer cells grow into a large mass and are able to evade the immune system response by upregulating PD-L1 secreting immunoinhibitory cytokines and recruiting tumor-promoting immune cells. The modified cancer cells also downregulate up tumor antigens, calreticulin and NKG2D ligands, which evade immune. Cytokines play a role in tumor promotion. While tumor-infiltrating lymphocytes work to eliminate cancer cells, they secrete cytokines that help tumor cells escape. These are called immunoinhibitory cytokine cells that recruit tumor-promoting immune cells. IL-2s are polarizing cytokine for Treg and Th2 cells. Tregs express FOXP3 genes that act as immunosuppressive, and Th2 turn off CDLs. B cells express PD-L1, which suppress proliferation and activation of tumor-specific T lymphocytes. All of these are functions needed to prevent autoimmunity, but if they act before cancer cells are eliminated, it will lead to escape. IL-10 and TGF-beta switch macrophage 1 into macrophage 2 and recruit myeloid-derived suppressor cells. Macrophages 2 help tumor growth by secreting VEGF and other growth factors, and myeloid-derived suppressor cells turn off innate cells. The mysterious Mr. Pip. More than 90% of breast cancers express the protein called prolactin inducible protein, or PIP. The role of PIP in breast cancer is a mystery, but it seems to play a role in the immune response. A recent study found that the loss of PIP in vivo led to defective type 1 T helper cell activity. This has led to the theory that PIP may inhibit breast tumorigenesis by enhancing anti-tumor immunity. It's hypothesized that PIP may bind to dendritic cell receptors, leading to the production of IL-12, which leads to CD4 plus Th1 and IFN gamma production that turns on TILs. However, its exact function remains unknown to this day. Symptoms. As spoken earlier in the presentation, there are many different types of breast cancer. Listed here are some general symptoms that an individual with any type of breast cancer can have. It's good to know that which symptoms one patient gets may differ in another. Sometimes a patient can have no symptoms, such as a lump, until the lump metastases occur due to cancer cells blocking the lymph node. This is why it is important to know your family history. Be educated and follow breast cancer early detection measures such as getting a mammogram. The picture on the top right is showing general steps of metastasis. As said in a previous slide, the most common secondary sites in breast cancer are in the bones, lungs, brain, and liver. When metastases occurs, there will be new symptoms and pain will arise in these secondary sites. Symptoms in the primary and secondary sites can be contributed from growth of the cancerous cells. Tissue and nerve damage have been linked to pain in breast cancer patients. We know from the lecture that tissue damage leads to inflammation, which can also lead to the release of cytokines such as IL-6, which causes fatigue and fever. Some studies have found the link between cytokines and chemokine to pain. The immune responses as described in previous slides can lead to the progression of cancer development and create an anti-tumor environment which involves chronic inflammation. Examples of cytokines linked to pain are TGF-beta and IL-10. The bottom right picture shows that the immune system and cancer are both contributed to many different symptoms that immunotherapy. What roles will immunotherapies play in breast cancer prevention and treatment? Can immunotherapies replace conventional breast cancer treatments? These are 3 questions that researchers are still looking for answers and would like to know to this day. If breast cancer research and clinical trials focus on immunotherapies, then immunotherapies will erase conventional treatments. The conventional methods of treatment of cancer are typically chemotherapy, radiation therapy, and surgery. However, these methods of treatment often have detrimental side effects and can leave the patient immunocompromised. Chemotherapy regimens have been known to decrease NK cell activities. Radiotherapy suppresses most immune markers and decreases T cell counts, such as lymphocyte counts and NK cell activity. Breast irradiation can also cause leukopenia in both young and older women in the breast cancer. The development of cancer immunotherapies is still in their infancy but have begun to gain new traction as research has shown positive results with less side effects. Antibody drug conjugates or ADCs are monoclonal antibodies that are conjugated with cytotoxins. The ADC binds to cancer antigens and undergoes receptor-mediated endocytosis. Once the ADC is internalized in the cancer cell, it can initiate lysosomal degradation of the cancer cell. ADC therapies are still undergoing investigation and far from having highly efficient clinical outcomes. In CRT therapy, thousands of the patient's own T cells are harvested in a lab and inactivated viruses introduce new genetic information into the T cell's DNA to reprogram it. The modified T cells are then able to express chimeric antigen receptor, and the CAR-T cells are infused back into the patient. The new receptors allow the T cells to latch onto the cancer cells and are then able to escape and destroy them. CAR-T has proven successful in other types of cancer, but is still new and needs more trials for breast cancer. It should be known that there is no definite cure for breast cancer. A patient can simply remain in remission and the cancer can always replicate too quickly for the immune system to completely eradicate it. Social, global, and economical impacts. Breast cancer is the second leading cause of cancer-related deaths in women aged 50 or younger. Breast cancer has a very big economical impact on the younger population, especially on women of color, more specifically the African American population. Women who have been diagnosed with the cancer not only have to face the health burdens, but the economical burdens. Between the years 1970 to 2008, there were 225,866 deaths because of the disease. This is accounted for an estimate of 7.89 million years of potential life lost, as well as a severe loss in the quality of productivity due to premature mortality. Currently, there are studies being done on how to better help working young women who have been affected by this cancer, as well as interventions and strategies to help flatten the curve on disproportionate impact on African American women. Benefits of breast cancer awareness include early detection, attention from new potential donors, new research projects, and educating the public on breast health as well as the disease itself. As mentioned in the previous slide, a lot of funding comes from bringing awareness to the disease. Breast cancer awareness brings in an estimated $6 billion each year, the majority of which will go towards funding research as well as educating the public on the disease. There are multiple organizations across the country dedicated to helping the cause. Some of these organizations will not only assist in funding research, but will also help breast cancer patients directly who have been heavily impacted by the economic strain of the disease. These organizations can offer grants, assisted living, payment for medical treatment, and even cover transportation expenses for the patient.